Welcome back to Guideline Central. My name is Dr. Tabitha Michaud, and today we'll be discussing the American Society of Clinical Oncology, or ASCO's, new guidelines titled The Treatment of Metastatic Colorectal Cancer, published in the Journal of Clinical Oncology, which is ASCO's main journal, October 17th, 2022. This guideline is intended to provide updated treatment recommendations for patients with resectable or initially unresectable metastatic colorectal cancer, and the target audience is going to be healthcare providers and medical oncologists caring for patients with metastatic colorectal cancer. For this guideline, ASCO convened an expert panel to do a systematic review of evidence identified through online searches in both PubMed and the Cochrane Library through June of 2022. These clinical practice recommendations are based on 5 systematic reviews and 10 randomized controlled trials. And so for each recommendation, there will be both a type and strength recommendation grading, as well as a quality of evidence grading. The evidence quality was assessed using the Cochrane Risk of Bias tool and elements of the grade quality assessment and recommendation development process. Now, ASCO gave 10 new treatment recommendations for the treatment of metastatic colorectal cancer, but there are quite a few abbreviations that we want to go through before going into the recommendations, starting with CRS, or cytoreductive surgery, CT, or chemotherapy, EGFR, epidermal growth factor receptor, FOLFIRI, which is folinic acid, fluorouracil, and irinotecan, FOLFOX, which is folinic acid, fluorouracil, and oxaliplatin, MSI-H, or macrosatellite instability high, MSS, microsatellite stable, SBRT, or stereotactic body radiation therapy, SIRT, selective internal radiation therapy, VEGF, VEGF, or vascular endothelial growth factor, DMMR, or deficient mismatch repair, MCRC, metastatic colorectal cancer, and pMMR, proficient DNA mismatch repair. And with that, we have 10 recommendations from ASCO on the treatment of metastatic colorectal cancer. So let's get into the guidelines. So for these recommendations from ASCO on the treatment of metastatic colorectal cancer, there's going to be 10 new updates, starting with our first recommendation, which was given a strong recommendation with a moderate quality of evidence. And here, ASCO recommends doublet backbone chemotherapy should be offered as first-line therapy to patients with initially unresectable microsatellite stable or proficient mismatch repair metastatic colorectal cancer. ASCO does also include a qualifying statement that treatment with capecitabine plus oxaliplatin may be substituted for folinic acid and oxaliplatin at the clinical discretion of the treating provider and in shared decision-making with the patient. Our second recommendation from ASCO was given a weak recommendation with a moderate quality of evidence, and here ASCO recommends triplet backbone chemotherapy may be offered as first-line therapy to selected patients with initially unresectable MSS or pMMR metastatic colorectal cancer. For recommendation 1 and recommendation 1.2 that we just went over, ASCO does include qualifying statements that all patients included in the evidence base for recommendations 1.1 and 1.2 received antivascular endothelial growth factor, antibody bevacizumab, in addition to doublet or triplet chemotherapy backbone. ASCO also recommends shared decision-making, including a discussion of the potential for benefit and risk of harm. While survival and recurrence outcomes are improved, number of grade 3 or greater adverse events are more frequent with triplet chemotherapy compared to doublet chemotherapy. Recommendation 2.1 from ASCO was given a strong recommendation with a moderate quality of evidence, and here ASCO recommends that pembrolizumab should be offered as first-line therapy to patients with microsatellite instability high or deficient mismatch repair metastatic colorectal cancer. Recommendation 3.1 from ASCO was also a strong recommendation with a moderate quality of evidence, and here ASCO recommends that EGFR therapy plus doublet chemotherapy should be offered as the first-line therapy to patients with MSS or pMMR left-sided RAS wild-type metastatic colorectal cancer. ASCO does include a qualifying statement for this recommendation that anti-EGFR therapy is not recommended as the first-line therapy for patients with right-sided RAS wild-type metastatic colorectal cancer, and consistent with qualifying statements to recommendation 1.1 and 1.2, these patients should be offered chemotherapy with anti-VEGF therapy. Also, anti-EGFR therapy is not recommended for patients with RAS mutant metastatic colorectal cancer. Anti-EGFR therapy with triplet chemotherapy is not recommended. Although anti-EGFR therapy is preferred, anti-VEGF therapy remains an active treatment option for patients with left-sided, treatment-naive RAS wild-type metastatic colorectal cancer in the first-line setting. And lastly, shared decision-making is recommended, including a discussion for the potential benefit and risk of harms, such as increased risk for treatment-related rash with anti-EGFR agents. Recommendation 4.1 from ASCO is another strong recommendation with a moderate quality of evidence, and here ASCO recommends that encorafenib plus cetuximab should be offered to patients with previously treated BRAF V600E mutant metastatic colorectal cancer that has progressed after at least one previous line of therapy. Recommendation 5.1 from ASCO is a weak recommendation with a moderate quality of evidence, and here ASCO recommends that CRS plus systemic chemotherapy may be recommended for selected patients with colorectal peritoneal metastasis. Now, ASCO does include a couple of qualifying statements with this recommendation, starting with, in the Prodigy 7 trial, 15% of patients with isolated colorectal peritoneal metastasis experienced no disease progression in the 5 years following surgery, indicating that CRS may be a curative option for an appropriately selected subgroup of patients. Now, this recommendation applies to patients who have been deemed amenable to complete resection of colorectal peritoneal metastasis, regardless of previous treatment, and who have no extraperitoneal metastasis. Additionally, complete macroscopic cytoreduction was achieved in 91% of patients in the Prodigy 7 trial, which is attributed to the majority of patients undergoing CRS at centers with substantial clinical experience. CRS should be considered as a treatment option only within these specialized centers. Also, multidisciplinary team management, or MDT, is recommended for patients with metastatic colorectal cancer who are considered candidates for CRS. The MDT should include expertise in medical oncology, surgical oncology, radiology, and pathology. And lastly, shared decision-making should include a discussion of the potential impact on quality of life and rate of adverse events associated with CRS. Recommendation 5.2 from ASCO is a strong recommendation with a moderate quality of evidence, and here ASCO recommends that oxaliplatin-based hyperthermic intraperitoneal chemotherapy is not recommended as an addition to CRS for treatment of patients with colorectal peritoneal metastasis. Recommendation 6.1 is a weak recommendation with a low quality of evidence, and here ASCO recommends that stereotactic body radiation therapy may be recommended following systemic therapy for patients with oligometastasis of the liver who are not considered candidates for resection. Recommendation 6.2 is a weak recommendation with a low quality of evidence, and here ASCO recommends selective internal radiation therapy is not routinely recommended for patients with metastatic colorectal cancer and unilobar or bilobar metastasis of the liver. Now for this recommendation number 6.2 and the one before, recommendation 6.1, ASCO does include qualifying statements that MDT management is required for patients with metastatic colorectal cancer who are considered candidates for stereotactic body radiation therapy or selective internal radiation therapy. The MDT should include expertise in medical oncology, radiation oncology, hepatobiliary surgery, and interventional radiology. And our last recommendation, recommendation 7.1 from ASCO, is a weak recommendation with a moderate quality of evidence, and here they recommend that surgery with or without perioperative chemotherapy should be offered to patients with metastatic colorectal cancer who are candidates for potentially curative resection of liver metastasis. ASCO does include a couple of qualifying statements for this recommendation, starting with perioperative chemotherapy may be more likely to be recommended over surgery alone in patients with a greater number of metastases or larger tumors. Shared decision-making, including discussions for potential risks and harms, are recommended, and you can find these listed in Table 10 in the full text guideline. The choice of perioperative chemotherapy or surgery alone and coordination of treatment sequencing should be discussed within a multidisciplinary team that includes expertise in medical oncology and hepatobiliary surgery. And lastly, perioperative chemotherapy is recommended for a total perioperative and postoperative duration of 6 months on the basis of total duration of chemotherapy in the EORTC 40983 trial. And that wraps up our treatment recommendations from ASCO on the treatment of metastatic colorectal cancer. Now, something that ASCO does include as a disclaimer with all of their recommendations and guidelines, and that's ASCO believes that cancer clinical trials are vital to inform medical decisions and improve cancer care, and that all patients should have the opportunity to participate. So there you have it, the 2022 Treatment of Metastatic Colorectal Cancer Guidelines. Now, if you're looking for more information about these recommendations or the guideline itself, you can find the link to the full text guideline as well as our pocket guide available on our website at guidelinescentral.com. While you're there, make sure to check out our hundreds of clinical practice guidelines from over 45 different medical societies, and we'll see you guys on the next guideline.